All right, we want to welcome everyone to this webinar this afternoon. I am Tammy Hott with the CERO Project, and we are so happy that you have joined us for this first webinar in the Road to HINAC 4 webinar series. Since postponing HINAC, or HIV is Not a Crime 4, to 2021, the Executive Committee discussed ways to keep people engaged and build momentum leading into leading to the Training Academy. Each partner organization, Positively Trans, Positive Women's Network, Thrive SS, CERO Project, and the USPL HIV Caucus will be hosting one of the webinars. Today the caucus is hosting Centering Lived and Living Experiences of Surveillance and Diagnosis, a public dialogue at the intersection of HIV and COVID-19 pandemics. And I will turn it over to Martin and the incredible panelists we have here today.
Thanks, Tammy. Thanks so much. Can everybody hear me okay? Okay, I'm gonna put the slides back up. Well, I just want to thank everybody. Thank you to Tammy and the HINAC Executive Committee for organizing this webinar series and for organizing today's webinar. My name is Martin French, and I use he, him, his pronouns. I teach in the Sociology and Anthropology Department at Concordia University in Montreal in Canada. And I'm also a member of the Canadian Coalition to Reform HIV Criminalization. I'm going to make a couple of acknowledgements and introductory remarks before turning the mic over to my co-chair, Dr. Andrew Spieldenner. So it's important to acknowledge that my university and my apartment, where I am today, is located on Indigenous lands. The Kanien'kehá:ka Nation is recognized as the custodians of these lands and their surrounding waters. Tiohtià:ke, otherwise known as Montreal, is historically known as a gathering place for many First Nations. Today, it is home to a diverse population of Indigenous peoples and other peoples. We respect the continued connection with the past, present, and future in our ongoing relationships with Indigenous and other peoples within the Montreal community. I also want to acknowledge Valerie Nicholson. In using the concept of lived and living experiences for our webinar title today, we are quoting Valerie. Valerie is a member of the Canadian Aboriginal AIDS Network and a steering committee member of the Canadian Coalition to Reform HIV Criminalization. Lived experience, she argues, signifies a past reality. We therefore need to augment this important concept by putting it into the present. We need to speak not only of lived experiences, but also of living experience. So with those acknowledgements in view, let me briefly introduce myself for those that don't know me. As I mentioned, I'm a sociologist. I study surveillance, risk, and social justice. I'm interested in critically examining how surveillance systems work, who they advantage and who they disadvantage. And I have been studying HIV surveillance in Canada and the United States for more than a decade. Can folks still hear me okay? So basically, assuming that it's all going good, thanks Stephen. And great to see you here. I just wanted to say that the other thing, you know, in addition to studying HIV surveillance for a number of years, I'm working on a book, writing a book. It's called CERO Surveillance. That's the title page. I don't really have the, you know, the subtitle picked out yet, but it might be For People, Not Molecules, or it might be humanizing HIV surveillance, or maybe negotiating HIV surveillance. I don't know yet, but you know, the book tries to situate current discussions about molecular HIV surveillance in relation to a broader social and historical context. And the argument in the book is that many forms of HIV surveillance paradoxically erase the embodied contribution of people living with HIV. And an implication of that, or perhaps a cause, is that people in communities most affected by HIV have not been in the driver's seat when it comes to making decisions about this type of surveillance. So my book manuscript is in the first draft, and I'd love to enlist the expertise of this community to help me develop these ideas that I'm working on, and that I'm working on also in conversation with others, including our amazing panelists. I'm also creating an open access course to try and translate the material in the book more broadly. It's intended for activists and advocates who want to know more about surveillance. So it would be amazing to get folks' feedback on how to translate this material for a broader audience. And if anyone is interested in in helping out with this, or you want to learn more, my contact information is on the slide that has my name on it. Thanks, thanks, Tammy. So please don't hesitate to send me an email. It'd be great to hear from you. And maybe we could go to the next slide, because I want to introduce now my co-chair, my amazing colleague and friend and mentor, Dr. Andrew Spieldenner. I first got to know Andy actually when we shared a room together at HINAC 2. So thanks to whoever made that fortuitous arrangement. You know, special thanks to Ciro, Sean, HINAC, all HINAC organizers and participants, past and present, for the vital community building work that you've done and are doing. We wouldn't, I don't think, be having this conversation today without the foundation laid by that work. Andy is vice chair of the US People Living with HIV Caucus, and he is also an associate professor of communication at California State University, San Marcos. And I would like to add, in my humble opinion, that Andy exemplifies the ideals of the public intellectual. Not only is he a brilliant and widely read scholar, but he has a real ability to translate complex knowledge into a format that's easy to understand. If you haven't read his stuff on pause.com yet, you should definitely check that out and you'll see what I mean. Andy, thanks for co-chairing this session with me. Before I turn the mic over to you, just to mention, in case you've just joined, that Andy is going to be moderating this, this discussion. So he'll ask our panelists to introduce themselves in a second, and then we'll have some discussion, questions to motivate the discussion amongst discussants. I'm gonna be monitoring the chat. So if you have any questions, if you're watching, you have any questions that you'd like for us to take up in the Q&A portion of this today's session, please pop them in there, and I'll do my best to compile all the questions and pose them to our panelists in the Q&A session. So I'll turn the mic over now to you, Andy. Over to you, thanks.
Thanks, Martin. Can you actually share your screen? It becomes complicated. I can't see everything on my computer if I'm sharing my screen.
I will do that, yep.
Thanks. So today we want to talk about the embodiment and the particular issues about surveillance from the points of view of people who are people who experience and who have experienced surveillance. And one of the reasons we want to do that is because often when we talk about surveillance, and we see a lot of public health jargon in the news now, everyone's talking about flattening the curve and social distancing, and there's all kinds of kind of public healthy stuff happening. But often the data is abstracted in a way, so you don't really get the sense of why or how that data is actually collected and who it's collected from and how it's monitored and who gets monitored more. So, you know, often when we see aggregated surveillance data, it's in reports like this: HIV in the United States in dependent areas, HIV in Canada, and not really located, you know, and it gives the idea that HIV is located in an area versus a body. And we really, you know, often our fights, especially as people living with HIV, have been like to acknowledge the work that we've already done in HIV, as well as the ways that our bodies, you know, we've used our bodies to help the entire public in HIV. We've, you know, our blood is used in surveillance, or, you know, we've taken part in research studies. Most of us have been studied many times. And all of this is is a contribution we've made that often goes unacknowledged, right? That our communities, you know, we're supposed to do that versus choosing to do that. And we've made choices as communities and as people to participate in certain kinds of things. And today we're gonna talk about surveillance, because often surveillance, particularly in molecular HIV surveillance, it raises a whole new set of questions for us. Martin, can you advance the slide? So I'm going to go through a couple ideas of what is molecular HIV surveillance, or I won't. But can you advance the slide? Thank you.
Sorry.
That's okay. When you type in molecular HIV surveillance in Google, these are the kinds of things that come up. So obviously it's very, one of the things that you'll note, first of all, is that it's very hard to find any of this information in easily accessible English, Spanish, or any other language. So I just want to put that out there, that when you are trying to find information about molecular HIV surveillance, it's often very difficult. It's not accessible. It's not easy to understand. And so I'm going to try to make it a little easier to understand, but I'm going to talk a little bit about where this molecular HIV surveillance is located. Next slide. So here you see the CDC definition of molecular HIV surveillance. One thing is, you know, that they want to talk about, that it identifies and responds to new HIV transmissions in order to be able to respond to relocate and refocus resources and programs into spaces with hotspots of places where they've had a number of HIV outbreaks or hepatitis C outbreaks. Now, I'm going to point out the reason this is called We Are People, Not Clusters. Oh no, that's another project we're working on. Sorry. But the reason we talk about this is because often molecular HIV surveillance identifies us as clusters. So we're part of networks of HIV, strains of HIV, actually. And so when we look at one of the ways in which this molecular HIV surveillance talks about us as people living with HIV is that it re-identifies us as clusters. And we really want to fight against that just because we're people. Next slide. So actually, one of the things about the CDC, so the CDC has put out molecular HIV surveillance, and I'll go into what it is in a minute, like how it's collected. But one of the things that's very clear that they rolled out this program, this initiative, this technology without community engagement. And so there's been this big tension in the community versus how this impacts us versus how surveillance is being conducted and whether it's good for us the way CDC envisions it's good for the people and public health. And one of the things to point out here is that CDC knows they have to defend molecular HIV surveillance, and this idea that they have to defend it should indicate that there's some challenges with it. And here they're acknowledging that they basically are saying that HIV criminalization concerns that we may have aren't really that big of a deal, and aren't part of the molecular HIV surveillance discussion, which of course I'd push back on. Next slide. So. Okay, we've got the defense. Can we go to the next? So, yeah, thank you. How this molecular HIV surveillance is actually done is it looks at phylogenetic sequences in our HIV to see how closely related viral strains are. And it procures the biomaterial. The blood that's used is actually the blood used in our clinic visits when they do drug resistance testing. For those of us living with HIV, we get drug resistance testing every time we have to change meds, at any time there's an addition or anything like that. Our doctors do it regularly. It is a point of care. It is the standard of care in the United States that we get drug resistance testing. The challenge here is we don't give consent for its use in surveillance, and that the actual blood, the material is repurposed for a different data set. That even though it's anonymized at the federal level, at the local level, they re-identify the data set because they have to be able to identify who these people are and do the contact tracing, which is another phrase that we are now more familiar with because of COVID-19. So when people are identified in molecular HIV surveillance, the idea is that to target the people that are least likely to be in care. Problem is the people the people least likely to be in care are those most marginalized by other social institutions. People who are homeless, people who use drugs, sex workers, people of trans experience, people of color, immigrants, and the list goes on. And we really have to note, like, why is that okay? And how does public health plan on intervening in lives that are already marginalized? Next slide. So some of our concerns and some of the questions that we may get to today are really is how, and a lot of the community dialogues, a lot of the discussions, and a lot of the places we're pushing our public health partners is to look at molecular HIV surveillance and HIV criminalization, to look at how it can be used in civil legal proceedings, immigration proceedings, public disclosures of people's HIV status, and reactivating medical mistrust. Because as I said before, all the populations that are least likely to be in care are already marginalized in our society. And so how does a surveillance system not increase that marginalization, as well as make us not want to go to our doctor for fear that our blood will be repurposed in other ways? I also want to note that one of the big concerns is that the ways that we've seen information deployed across federal agencies and the ways that our data has not been protected is a big concern for us. And we're seeing more and more in COVID-19, for instance, the rapid degradation of privacy rights. And this has particular challenges for people like there's, you know, if you're an immigrant, will that data be used against you for immigration proceedings? And, you know, is it really protected? Because it doesn't seem like our data sets, any data is protected from law enforcement in this country. It doesn't seem like that at all. And that's kind of frightening. So anyways, I think that's my introduction. Okay. And so we're gonna allow the panelists to introduce themselves, right, Martin? And then we'll get.
Yeah, sorry, I had my mic off. Yeah, that's right, Andy. If folks want to just briefly introduce themselves, maybe say, you know, their names, what pronouns they use, you know, the organizations you're connected with. We can popcorn, or I think I have a slide order here. So Nana, I realize I'm putting you on the spot, but maybe we could start with Nana. And I think it's going to be Marco and Max and Alex. Yeah, so please, Nana, if you want to introduce yourself, that would be great. Andy, did you have anything more to say though before we start the introductions?
No.
Okay, over to you, Nana, please.
Hi, everyone. So great to see you all here. I'm really looking forward to this conversation. Nana Khanna, she, her, or they, Executive Director of Positive Women's Network USA, and also Positive Women's Network Action Fund, a connected 501c4 organization. And I also serve on the steering committee for HIV Racial Justice now. Looking forward to this conversation.
Thanks, Nana. Marco?
Hi, everyone. Can you hear me?
Yes, we can.
Yep, Martin.
Yes, perfect.
My name is Marco Castro-Bojorquez. Thank you, Martin. I'm very honored to be here. I'm very humbled to be here. I have this amazing opportunity to engage with some of the most brilliant people that I have ever met, which is all of my co-panelists and everybody who is actually involved in this webinar. I use male pronouns, and I work with the HIV, with the U.S. people living with HIV caucus. I'm sorry, I have a kitten that is driving me crazy. And I also work with HIV Racial Justice now as a co-chair. And thanks for being here. Everyone that is in the audience, please engage with us in the chat box. Let us know where you're coming from or where you're connecting from. And I'm looking forward to talk to you all.
Awesome, thank you, Marco. Max?
Hey everybody, Maxx Boykin, he, him, his pronouns, here with the Black AIDS Institute. I'm the Policy and Organizing Manager, come out of the Black Treatment Advocates Network and help lead that nationally, where we have 26 chapters and affiliates across the country. And just, I'm excited to have this conversation with some of the smartest minds that I know, and get a chance to continue to be a part of. I also sit on the steering committee of HIV Racial Justice Now and the Collaborative for Health Equity Cook County. And we'll be talking about just also ways in which surveillance has impacted, I think, not just within the HIV community, but its impact also largely on the Black community, and how that also adds to our larger medical mistrust and ways to fight back against it.
Awesome. Thanks, Max. Alex?
Hi, everyone. It's a real honor to be here with all of you. I'm sending lots of love and respect and solidarity. I'm coming to you from the unceded territory of the Algonquin First Nation, also known as Ottawa, Canada's capital. I'm a member of the Canadian Coalition to Reform HIV Criminalization and AIDS Action Now, and I'm also an assistant professor of criminology at Carleton University. And just before this call, my friend Steve, who's been incarcerated in Canada for HIV, on charges of HIV non-disclosure for 9.5 years, called. We're negotiating his release, and he's being released on September 8th, and he's sending lots of love and solidarity to everyone on this call. I just thought I'd share that with you. Very much looking forward to this conversation today.
Awesome. Thanks, Alex. Andy, I'm going to stop sharing my screen now, and I think I'll turn the mic back to you. That's okay?
Cool. So a couple things. Thank you, Alex. That's amazing news. Very happy to hear that. Why they want to put us in prison, I have no idea, but I'm tired of it. So if you need questions about defunding the police, you can Google it. There's lots of great information out there about why that's a necessary part in our struggle. Okay, so I am going to be leading an open-ended conversation. And so my goal here is just, again, these are extraordinary people I've had the pleasure of working with, and I'd love to kind of just start some questions your way. There's already been some questions in the Q&A box that we'll get to later on in the conversation. But I wanted to, we've talked about surveillance, diagnosis. One of the things I'd really love to hear from Nana, Marco, everybody. So the first question is, why do you think the HIV community is uniquely positioned in this moment to talk about surveillance and diagnosis? Nana?
Sure. So let me just I just want to back up for a second and really center exactly what we're talking about. So what Andy has just kind of gone over with us and what Martin has introduced is really a process by which the genomic sequence data is being taken from people living with HIV without our knowledge and without our consent. So that's the first thing that is happening, is that we didn't know, that our data was being used in this type of way. When we go to get our blood work done, or when we go to get an HIV test, our viral genome is sequenced. That sequence of our virus is then shared with public health and federal authorities, and it is compared across a large database. And they're basically looking for linked diagnoses happening within a short amount of time. And so this is what CDC is saying they're using to track what they call outbreaks or clusters of HIV transmission so that they can intervene on them. Their assertion has been that the data is anonymized before it goes to them, so it can't be connected to individuals. But and their, a lot of their assertions are basically, hey, you should just trust us to hold this data for you, right? And I think hopefully we are not really confused about why trusting these systems might not be the best idea for Black folks, for immigrants, for people who are engaged in labor that is criminalized, for people who use substances that are criminalized and things like that. And so particularly in this moment. But this is a practice that has been going on for a while, to one extent or another. The difference is that over the last couple of years, it has been dramatically scaled up. And so that's one of the reasons that we're bringing attention to this practice of molecular HIV surveillance, because basically, what happens is if these viral sequences that they're looking at over, I think like a 6-month period, have less than 0.5% variation or something, they say, hey, there's an outbreak happening here. When you look at an outbreak that's happening, you're looking at linked diagnoses. And in a situation where we have, you know, more than 24 states and US territories that criminalize HIV transmission, this opens up a lot of conditions for vulnerability for people living with HIV. We are also in an environment where immigrants have been targeted for utilizing healthcare related services or public benefits. And that has been used as a condition in immigration proceedings and determinations of immigration status. And so, and literally this government and this administration changed the definition of what they call public charge, which is the determination of whether an immigrant is likely to become a burden on society. And they changed it explicitly to include things like having an expensive health condition. So, you know, HIV is obviously an expensive health condition. So when the, you know, when the CDC is asking us to just sort of like trust them to use this data responsibly, that raises a lot of questions for people who are advocates for human rights and social justice, and who really understand that these types of surveillance systems are not disconnected from policing of Black people, from policing of Latinx communities, from policing of immigrants, from policing of trans folks, from policing of sex workers and people who use drugs. And so that's the environment in which we're having this conversation. So number one, you know, we haven't, people living with HIV, and I am a person living with HIV, have not consented to having our data taken and used in this type of way. We did not know that our data was being taken and used in this type of way. And now with this new federal and the epidemic plan that came out of the occupant of the White House, that plan actually rests on 4 pillars. And one of those pillars to end the epidemic is molecular HIV surveillance. And so the resources and infrastructure now that are being deployed in our communities to address the HIV epidemic are dependent on, are very much resting on a bedrock of this surveillance system that has really not been vetted by the community, and that in fact presents a lot of concerns. And so in terms of relationship to this moment, you know, I think that we'll probably talk about this later, but a lot of the COVID-19 response, coronavirus response, is not, it's not dissimilar from how the HIV public health infrastructure has been utilized. And in fact, it is relying on a lot of best practices learned from HIV and STI public health interventions like contact tracing and like surveillance systems. And so, because we as the HIV community have a lot of experience around what doesn't work with those systems and how they need to be improved, some problems with them, and criminalization of people living with HIV, we understand the implications of some of what's happening with COVID-19 in a way that maybe other communities don't. And so I would argue that we certainly have a responsibility to be present and active in these spaces that are thinking about how technology and surveillance gets deployed in COVID-19 in this moment. I'll stop there for the moment.
Thank you, Naina. I'm trying to get the information that has been asked in the chat. So I've just, so I'm a little discombobulated. Do people want to kind of riff and enhance and what Naina started?
I do. Andy, I wanted to say that I agree 100% with Naina. I also think that the community that has been fighting for HIV since the inception, since the Denver Principles, were a group of people that were living with AIDS at the time, declare their desire to be engaged in all aspects of their condition. I always say that people living with HIV change forever how public health is managed, or basically change public health in general. And so we have been fighting since the time that Donald Trump took office. We have been fighting nonstop, constant attacks to all of our communities. The Latinx community has been the target of like nonstop attacks by the government, and so that puts us in a position where, like Naina said, it's our duty to share the experience that we have with HIV. So COVID-19 is not a disaster, which oddly enough, it is a disaster. And my point to that is that typically dictators or authoritarian leaders use a moment, a threat, to actually take on to take on and control populations. And so we need to be very careful not to give away all of our freedoms, so we are not becoming what is happening in other countries where there is like cameras everywhere that they have facial recognition, and where there is a moment of privacy. I think that it's really important that we also maintain some independence, and that we counter what an entity like CDC is trying to do. I think that it's important that we also stay together, that we are solidary, especially in these times. And since the moment that I learned about HIV molecular surveillance, I knew that I needed to be involved. There was no question, because I know that my community is one of those communities that is it's basically facing the most challenges. I'll stop.
Alex, Mark, Max, did you want to jump in? Or?
You're muted.
I would just add, I think Naina and Marco really, set the tone on that one. And thinking about, when we think about now how COVID-19 is being, can be criminalized, we also have to think about how in which, the ways in which we've seen it differently, different people that look at different ways, specifically people of a darker tone, and the anti-Black racism that we have seen connected to this, where communities that live in more urban areas, communities that look more like myself, will be criminalized in a different way. Folks that are traditionally more immigrant populations also being looked at different ways. And we also have to talk about just the overall xenophobia that has been connected around COVID-19. And I think something that also folks that work within HIV, we also understand that we have also been continuously fighting against those norms, or those what is considered normative by others, to be like, if this normalized straight cisgendered white man is okay, then everyone else should be okay as well. And as we've seen most recently from the administration's Axios interview, that there's only certain, it's okay if certain people die, because those certain people aren't of the certain demographic that they care about. And I think there's a history of us fighting against that within the HIV work, and now we are also seeing it continuously needed around COVID-19.
Thanks, Max. I'll just say something quick, but I think I've repeated this kind of saying a bunch of times on different webinars I've been on recently, but I think whenever we're talking about public health, and whenever we look at public health measures, not just molecular HIV surveillance, but everything that people living with HIV have been subject to, I use the question that comes from Gary Kinsman, who's the founder of AIDS Action Now in Canada, Canada's version of ACT UP, a legendary gay rights and AIDS activist. And he always says, when we think of public health, we have to think of who is the public and whose health are we talking about. And people living with HIV have never been the public in public health. We're always the people from which the imaginary public is to be protected. So we're an object of risk. we're a subject of research, we're never the public in public health. And I think when we think about surveillance, that means surveillance that's targeting us is about extracting information from our bodies for someone else's benefit, not for the benefit of our own community. And that's what molecular HIV surveillance is doing. It's people in a laboratory who have nothing to do with our communities, extracting our own biomaterial to use that to protect the public, not with our own interests at heart. And I think that that's a really important question and framing to use when we talk about all of these kind of new interventions. And with COVID, I think we've just seen, I think one of the reasons why people living with HIV are well positioned is because whatever's happened with whatever's happening with COVID right now has been previously tested on marginalized people for decades in other pandemics. So the rollout or the criminalization of COVID that we've seen coming has been previously tested on all of us. People living with HIV, people with communicable diseases have faced all of these forms of control and surveillance of the past. So that makes us well positioned to kind of critique and understand what's happening now with COVID.
There's some questions that have come up that are all over the place. Thank you all. A couple, I'd like to kind of reframe a bit. So you brought up some great issues around the intersections. I have a question about how, like, all of you have been involved in activism around this issue. What are some things that you've been doing? What are some ways for people to get involved? And then I'll do a follow-up question about the responses of the ASO community, which is a question in the Q&A, which I think is brilliant, as well as what's been the response from CDC about all the work that you've been doing. So what's some of the stuff that you've been doing, and can you highlight some of it so that people can see some of the various kinds of interventions that have been happening? One question from the chat that I want to highlight is from Facebook Live is, when did we first realize that that MHS was operationalized? And I think we found out at HINAC that somebody brought it to our attention, and we did an emergency meeting at HIV is Not a Crime in Indianapolis. And we thought like 3 people would show up to this meeting, and it was like a packed room. And everyone was kind of shocked that this was even happening. One of the ways that we found out was that CDC put out a funding announcement for it, for all health departments. And so we were just shocked to find out that, number one, this had been going on, this has been piloted and tested for 10 years, and that then it had been nationalized without our knowledge. So that's, for the person who asked the question, for Kamaria, who asked the question about funding, the original funding portfolio in 2018 was $2 billion for this, for 61 announcements, 61 fund contracts with health departments. So just putting that out there. Okay, so what are some interventions that have been going on? What have you been doing? What are some ways for people to kind of keep tabs on this, get involved? Alex, you wanna go first? Or PWN, Naina, either way.
I can go quick. I mean, in terms of molecular HIV surveillance, I mean, I'm positioned in a kind of joint activist academic world. So there's been some resistance to molecular HIV surveillance work in academia. So a group of us who are on this webinar and some others have been responding publicly to researchers who've done molecular HIV surveillance and kind of trying to get our commentaries in journals about critiques about the criminalization and consent concerns. So we did that to a Lancet article that was on trans women, looking at molecular HIV surveillance of trans women in California, and kind of got a public commentary critiquing that none of the women involved in that study gave their consent to participate. And there'll be another article coming out soon. I mean, in terms of COVID, I'm involved in a project called Policing the Pandemic, where we've been documenting, I can just put the link in the chat, we've been documenting the policing and forms of enforcement that have been coming across in Canada, and the ramp up of police power and geolocating those on a map and trying to create commentary and critique about the role of police collaborations with public health, and the fact that police have been positioned as a legitimate actor in response to COVID, and that police should be understood as not as a legitimate actor in responding to any so complex social problem like a pandemic. And that the analysis that we've applied to COVID has come from work that has been going on for years from the criminalization of HIV. So that's been applied to this realm now today.
Yeah, I guess again, there's lots of work going on, and lots of things have been happening to push back. But I think it's really important for us all to just think about how we can play a role in thinking critically about how data and surveillance get deployed in our communities. And so, data is never neutral. It's never power neutral, and surveillance is never power neutral. There are lots of different forms of surveillance that are impacting our communities, and as we slide further and further into an authoritarian and fascist state, I hope that as a community we are mindful about implications for communities that are really vulnerable in this environment, and really call into question these types of data sharing practices. So, there's a long legacy of struggle around HIV data itself. Over decades, right? That has been taking place. The actual ideas of how data should be collected, who it should be shared with, how it should be shared, what types of protections are in place, do people get to consent, and in what kinds of ways, have been a totally contested area and continue to be a contested area, right? Just think about like opt-in versus opt-out testing as an example. That same discourse is happening in relation to COVID-19. And it is happening in ways that are even more risky and more dangerous because technology has substantially advanced, and the ability to share data and information quickly and in real time has substantially advanced. And so, right now in the era of coronavirus, for example, there have been laws, policies, and practices coming into place in states around the country that are really different levels of invasiveness, ranging from sharing data about households where people tested positive for coronavirus with first responders so that they have that information when they show up. You can imagine what type of, you can imagine what we would think if somebody did that with HIV data, right? Imagine if anytime you called an ambulance or you needed to call for some kind of medical attention, or you called like the fire truck to come and respond. Imagine if they knew that somebody living with HIV lives there. Imagine what that would mean. Imagine if every time ICE came to knock on someone's door, they knew that they were knocking on the door of somebody living with HIV or with COVID-19. So, in terms of, I guess just to get back to Andy's question, what's been happening? There have been folks fighting these types of data incursions for a very long time, specifically in the case of molecular HIV surveillance. We've kind of been organizing a resistance movement around this since HINAC 2018 that we would invite folks to get involved in. You can email any of us who are on this call to get looped into that work. PWN has also been involved in work around policing of COVID-19 and criminalization of COVID-19. And there are some websites that I will drop into the chat box here. Some of the work that is active and alive right now is around legislation like data security and privacy legislation that is currently moving through Congress about how COVID-19 data will be protected and used. And this is very important for people living with HIV and advocates for people living with HIV to pay attention to, because these data sharing practices will not only apply to one disease state, right? Things that get put into place now are likely to have downstream implications. And the types of public health interventions or really criminal justice type interventions that get legitimized right now based on this pandemic can be extrapolated and can be used for other people. And these are the cases that many of us in the HIV community have always made, that, you know, HIV itself is not the problem. We're not out here, at least from PWN's perspective, we're not out here to end the HIV epidemic. We're out here to end the structural violence that creates the context in which Black people, brown people, low-income folks, queer and trans folks are the ones who are most likely to suffer and die because of a pandemic like HIV, like COVID-19. That's what we're here to do. And I think we have to stay laser focused on that work. And for advocates in the US context, because we know that all of these local MV epidemic plans are resting on the bedrock of molecular HIV surveillance, that means that every single one of you that's in a place where you have an ETE piece or component of funding or a planning group that is meeting, you can be raising these issues in that space. You can be pushing back, you can be asking hard questions, and we can help you with figuring out what some of those questions might be and creating a peer learning environment where we can push back together.
Yeah, I just want to add to what Naina was saying, that to continue to be ever vigilant around the EHE work that is going on in local jurisdictions. One of the things that we, our Black Treatment Advocates Network, is when we are learning about this and also continuously educating our own network around like the changes. What does this mean around the molecular surveillance? And thank you all to everything, that's all the comments and questions that are being in the chat. Y'all keeping it real spicy. And as we think about like, we do know people that are at different bodies, but I also know through some of the advocacy that folks have been doing in the state of Georgia to actually make sure that for Fulton County, there was no connection to molecular surveillance and the money going into that. And so when they actually are going for their CDC grant, they're choosing not to go and focus around the molecular surveillance piece. I know that was a push and internally, and from advocates that I also know that we train, know, and understand this work, and know that there was worries around molecular surveillance, and these actually also came from people living with HIV and allies that could also advocate for those changes. So those are some of the important things to be able to do. Built within many of these ending the HIV epidemic plans, there was a piece around molecular surveillance built into it because it is one of the pillars. We have to educate our communities constantly on why that's not okay, but also educating folks that work in health departments and different things and saying like, that's not necessarily needed in order for the amount of funds that you need to get it, but also understanding that does impact someone's potential or ability to get all the funds that they want to in the HIV epidemic, which I know that can be conflicting, especially for a health department that is in need of support around this. So being able to do the proper education around this and also, rallying our advocates around these issues. I continue to think about the continued work around PWN, and I think they've been one of the leaders around this, if not the leader around it, and just continue spreading that information, making sure that folks understand, and understanding that we have to create spaces where folks are able to have these conversations in larger health bodies around like what is the active surveillance and how does that show up. And then lastly, also the continued active right on understanding how molecular surveillance actually adds to medical mistrust. And it makes it harder for us to get more Black folks to be a part of studies, for getting communities of color more involved within the new changes. And that makes it very hard for us to end a new pandemic that is now disproportionately impacting our communities. And so another thing is that we've done these continued webinar series around the truth and giving folks the updates about really what's going on around COVID-19. We've done that as a partnership. We have our next webinar, and we actually get the deputy director from PWN to speak on that one tomorrow, Benita Ray, and talk about some of the politics that's been going around what is the politics around COVID-19, because that's also something that has been deeply important and something that of how do we push these policies issues to change the way that folks are being criminalized around any type of surveillance, but most of the molecular surveillance that we're seeing expounded upon within this administration.
Thank you, Max. Thanks, Nana. Thank you, Alex. One of the questions that has come up is, and it's related because some of what you're talking about is like, where are we seated? Where are we able to get access? Where can we interrupt, disrupt, ask questions? be critical about the ways in which data is presented to us and how it's collected, be critical in who gets impacted more, right? But one of the questions is, what is the, have there been good partnerships with various parts of the HIV sector? How has the HIV sector been animated, activated in intervening in this kind of ramp up of surveillance across the board? Or have people not really known what's going on? And do we have to do interventions not only at the individual level, but at the organizational level? Like, what's the sense there?
I will start very quickly. I will say, first of all, I will say that the biggest issue that I have with molecular HIV surveillance is that the CDC is connected to the police, to ICE, to all of these injustice entities for people like myself. And I think that I would think differently about molecular HIV surveillance if I didn't have to fear that by going to get tested for HIV or by becoming HIV positive, I will also put my life at risk of being put in jail or in detention centers, or basically just losing your freedom. I think that there is enough for us to deal with HIV as it is, for us to have to deal with the worry of criminalization, and then the worry that our blood is going to be used without our consent for all kinds of things that we don't even understand. The people, normal people that are not involved in these issues, it's hard for them to wrap their mind around this issue. What I do personally is that I talk to every single person that I know, that I have a conversation, that I have a report. I tell them about molecular HIV surveillance. And the community hasn't been extremely, the HIV movement has not been super embracing this issue, because I think that a lot of people don't think that affects them. In the case of the immigrant movement, although they do great work with projects like no, let me see, the projects that is called No Tech for ICE, which the immigrant movement, especially Mi Gente, has done amazing work, because Latinx communities are completely over-policed and everywhere, right? And people need to understand that they're actually, the reason for that is because the detention centers are also a business. And that's a result of capitalism. And the people that are actually hold these people that are not criminals, that are most of them asylum seekers, just by having somebody in a detention center, they're making tons of money. I heard a report on one of the radio podcasts that talk on immigration, that actually in the entrance of this detention center, where there were like sick women, children, people afraid, there was this big sign where the people from that particular detention center were actually looking at how great the company was doing in Wall Street, and I found that's incredible. That is actually in your face. It's a business, and as far as I remember, there was the war on drugs, the war on all kinds of things, and surveillance. I think that again, if we don't really work together and do cross movement work around this issue, we are in danger of losing our independence and this great thing that people talk about America. So I think that people can talk a little bit about how the other folks can talk about how the HIV movement has responded, but I would say that the way that they have responded so far, in my opinion, is not enough. That we need more actually more involvement of everybody that is affected by this issue, and that we also need for allies to join us in the struggle, because I think that if I'm being affected by something like HIV molecular surveillance, people are affected as well.
Thanks, Marco. I think, I love the ties that you made with kinds of how not only the various nonprofit sectors and the various movements need to kind of be aware of this and how it impacts all of us. One of the questions from the Q&A box was specifically about how MHS can be used in immigration proceedings. And we've seen that there's very little firewall between federal agencies, that it's relatively easy to open the data streams for federal agencies, which includes immigration. I think one of the things to keep in mind, and when we're talking about these cases, we're actually talking about real cases. One of the first quote unquote clusters or HIV outbreaks was identified in 2 groups of Latino gay men, Latinx gay men. And the language around it was around containing them before they cross state lines. So I think we really need to be cognizant that these are real people. And when we bring these up, these are rooted in real investigations that have been done on people. So I just want to keep in mind that these are that these are actual things that happen.
Right, which very quickly, and that's a manifestation of racism right there. To me, molecular HIV surveillance is a racist tactic. And I feel like also very offended when the CDC thinks that the response that they have given to us so far is enough. That we are just people that are like, perpetually like against it. The work that we do, like opposition advocacy, it takes a lot of effort for us to be constantly trying to bring those issues, because people don't understand that we are not clusters. We are people. We are not just numbers or molecules. We are people. We're human beings. And actually, besides racism, or besides me consider that racist, there is also a huge violation on human rights. I'll stop.
I think, thank you for that, Marco. And I think that one of the things that the CDC says and other practitioners of molecular HIV surveillance is they justify the idea that they don't need consent because they don't want to have participation bias. They want to be able to capture everybody. And I think what you're saying, and I think that's important across through all of this conversation, is there's lots of people who can't or don't want to participate in harmful white supremacist structures like public health. And they will do what they need to do in their own communities to take care of themselves. And just because they're not participating in state public health infrastructure doesn't mean they aren't taking care of themselves. And I think that that's the kind of racist, patronizing way that public health operates, that we need to ensure that everyone can participate because we have this benevolent objective. But when you're the target of public health surveillance as not the public, that has material consequences in your lives: criminalization, violence, deportation, all kinds of things. But public health officials have this idea that they're just acting with benevolence and they don't see the other harm, or they kind of just tune it out. But I think that's something that's really important to note, how racist this structure.
Yeah, I just want to tie in what Martin had brought in there. I think that was a really important piece. Is like, hey, the reason folks don't feel, and I think this goes back to like why folks, have a fundamental mistrust, and especially certain communities have a fundamental mistrust of what public health is like public health tries to come in this very like nice, oh, we need everyone's information so this can be the good for everyone. The problem is when the forces are actually put against the communities, it's the communities that are othered, that are not considered the normative communities that are most impacted. And when police presence is put upon it, it is historically in a way and in a force that is very abusive in nature, and that is the state or federal government or whatever government agency putting putting its force on people's neck to make sure that you are doing this particular thing that we need you to do, while other communities are not treated in that same way. And we have seen disproportionately how that looks for Black and Latinx communities of being treated a certain way when they are being around this, and while they're also being disproportionately impacted by this, by COVID-19 is really where that struggle continues to happen, and why we will continue to have folks not trust and be able to trust what's coming out on the federal government. And it's also in this time, particularly when we have so much misinformation, wrong information, and blatant lies that come out of the federal government on the United States side, along with just our states and local jurisdictions being so confused on what's going on, it is very hard. And then to still see the people that are disproportionately criminalized by this being Black and brown folks is how we see this continue to perpetuate. And that will mean people will divest from those systems or continue to use in that public health system and say that they will find their other ways, in which we are seeing, unfortunately, people doing, and sometimes in a harmful way, because they are still not getting the best information around what and how this new pandemic is impacting us.
And I would also add to all the brilliant comments that have been made that the moment to contest these narratives around dangerous bodies and, you know, kind of like the danger presented by people living with HIV, the danger presented by people with coronavirus, it is so important that we push back on this discursive conversation now and in all ways that we can. So, you know, we've kind of named a lot of sites of intervention for like policy intervention or public health intervention, but this is also there is a normalization that is happening around seeing people with disease or with illness as something to be contained. And this is something that we have always had to fight as an HIV community. And this is something that like actually impacts everyone, even though always like Black folks, BIPOC folks, queer and trans folks will always be disproportionately harmed. Everybody will be harmed in the long run. You know, we've seen how in the early days of the HIV epidemic, cisgender women with HIV were viewed and continue to be viewed in many ways as like sites of potential danger to our unborn children. Right? That's just another example of how this type of ideology plays out. And so what's happening right now with the discourse around like quarantining, you know, policing, surveilling people with coronavirus is not going to be separate from the way people think about people with HIV in the long run. And the more that these kinds of ideas get normalized, that people with disease or sickness or something that is transmittable must be contained, the more dangerous that is in terms of what types of like policies and practices could be put in place in the future and how these technologies could be deployed in the future that will be harmful. So all that to say, like, I think we also have opportunities to interrogate how that is coming up even within our own families, within our own communities, in our social circles in this moment, because people are being massively targeted also with disinformation right now by very sophisticated campaigns that have a particular political agenda and with millions and millions of dollars behind it. So it is our responsibility to try to push back on all of this together right now. And the HIV community is really well positioned to do that. Like the HIV community, you as advocates, as community leaders, as public health leaders are trusted on issues of public health. Talk to your people. Talk to your people right now about what is happening.
Thank you, Nana. You brought us, I'd like to like kind of guide us towards, you know, solutions and victories. So thanks for bringing up points of intervention. You know, when people talk about, you know, contact tracing and how great it is or something, question it, you know, and I think it's important that even just questioning how it happens and who does it. You know, I'm pretty public about this, but I've been a part of a couple syphilis investigations where in both cases, the person who was from the public health departments threatened me with the police if I didn't give them names. So this contact tracing is not neutral. It's not a friendly process where people like walk you hand in hand through your trauma. You know, it's an investigation. And I think it's important to kind of raise up those power differentials that can happen, especially as law enforcement is deployed in government actions. And I think surveillance is a way that we can see that law enforcement's easily deployed for public health purposes. But I wanted to talk about victories and solutions and strategies. So what are some things, what are some critical questions that people can raise? What are some recommendations you have for folks on this? There is a question in the question box about how do we create safe spaces in this kind of surveillance state? And I don't know if there's a way to create it, but if anybody wants to touch on that or what you mean by a safe space even, that'd be great. So anyone want to start off? Solutions, strategies, recommendations?
I think that, I mean, like, I look to people living with HIV who always, or people who use drugs, or sex workers, or queers, and people of color who've always worked amongst themselves to figure out solutions, regardless of state forms of oppression and marginalization. And I think, so in Canada, people living with HIV have been self-organizing to protect themselves from criminalization, using strategies in their own community to keep themselves off the public health record. We made a little tiny magazine called How to Have Sex in a Police State, which I'll share with everyone, which is just like strategies to protect yourself that are to keep yourself away from public health surveillance. And I think that similarly under COVID, there's a project here in Canada run by gay men who use drugs called Fagdemic, which is using harm reduction principles to talk to each other about gay men who are still having sex, still hooking up in the context of COVID, and how to do that and how to protect each other and support each other. And I think that we always have to look to ourselves instead of the state, or instead of to people that aren't within our communities. And I think we're also, I mean, looking at the social context, we're also in a moment, a really, really legendary moment of a racial justice uprising led by the Black Lives Matter movement, which has led to a mainstream conversation about the defunding and disarming of police. And when we talk about that, we also have to talk about undoing and abolishing partnerships with police and public health, and undoing the forms of carceral public health that are rooted in forms of shunning and getting rid of people, moving them out of communities, viewing them as objects to be controlled, like Naina was saying. So I think we have an opportunity in the HIV response and HIV, as people living with HIV, to bring those conversations forward and say, look, these forms of public health are operating in a carceral way, in a policing way. And if we're gonna undo these forms of oppression and undo policing, we have to also undo the harmful approaches to public health, which are view us as targets and subjects and people to be surveilled of, not as people to be engaged with who have rights and dignity.
I love that. I wanted to say that communities have organized, and I wanted to uplift, for example, around coronavirus or COVID-19. In San Francisco, there is a group who actually created a task force to provide resources to the community that has been suffering because of gentrification. And they started in the Mission, my old stomping grounds in San Francisco. And I'm very proud of that effort. It's basically a community effort in the Rio Grande Valley that is being disseminated right now with COVID-19. There is a group that is called Angry Tias and Abuelas. And this is a group of women, which, by the way, if women just take the lead of this world, we will be way better. This group of abuelas and tias in the Rio Grande Valley, they organize and they support immigrants that are living in the encampment right there, but also in the detention centers around that area. And just an example for you all, if you want to do something right now, there is a group of 50, I think that 53 families in a town or in Dili, which is a detention center. They have been there for 100 days, and more than half of them have been there for 300 days. These are families that have to eat reheated food. They don't have any medication. The guards return from partying to their work, and they hug their children without their consent, and they don't use masks. And these folks are there just waiting for them and these folks didn't commit any crime. They just happened to try to come into this country because this country had decimated their economy in their Central American cities and countries. And so these families right now that are in this detention center in Texas, which is one of the most challenged by COVID-19, are requesting for letters of support. So I'm gonna put the information in the chat box so you all can write a letter and be involved in actually doing something productive. And lastly, I will say that it will be great for everybody that is in this webinar to just do some research on your own, so you can make your own decisions about it. There is a lot of information out there, not as much as I wanted in Spanish, but there is some information out there that you can actually research. And the last thing that I'll say is that think about human rights and molecular HIV surveillance. Do some research. And here, Alex and Martin are amazing folks that are doing incredible work in Canada. And I also want to uplift the work that the Coalition Against the Criminalization of HIV in Mexico is doing as well. And so I wanted to just mention them because I think that we all have got together at the HINAC conferences, and I think that the work that people are doing in other countries is also really important.
Thanks. Naina, Maxx?
Sure. I will just, I guess like one thing to go back to the questions that have been raised about, a couple of questions that have been raised. One about like, how has the HIV community responded or taken this up? And also this question of like, what do we know about how this has been used in terms of immigration? I want to say a couple of things. One is, you know, the HIV community is kind of often plagued by what I call the 3 Bs, like a focus on biomedical approaches, Band-Aid solutions, and behavior. We have a real like resistance within the community to actually addressing structural issues and human rights issues. We have a real resistance within our own community to prioritizing the voices and perspectives of people living with HIV, especially those from most impacted communities, especially Black folks, especially Latinx folks, especially non-English speakers, especially low-income folks, especially folks without a lot of formal education privilege or class privilege. And so there are lots of ways in which the 1.1 million people living with HIV in this country are not actually accurately represented in at policy tables and advocacy tables where priorities are getting set for the advocacy agenda, for the research agenda, and the public health agenda. And so I think that the response around molecular HIV surveillance has also been constrained by those things. And here's some feedback. Has also been constrained by that exactly, where there have been people living with HIV advocates and allies who have been trying to move this conversation, and it has not been taken seriously. We have been asked to put our concerns about surveillance and policing to the side in the interest of funding for prevention services and funding for biomedical interventions and resource allocation for disease intervention specialists and things like that. And that is really not acceptable. And I hope that, I hope that folks are understanding that when we got up and took the stage at USCA last year and spoke directly to Dr. Redfield, and it was a large group of folks, mostly people living with HIV, who got up to say, we are people, we are not just clusters, we are not just our genomic sequences, we are actually human beings. That led to a closed door meeting with Dr. Redfield, who we know has a history of promoting things like quarantining people living with HIV in the first place, right? But we directly asked Dr. Redfield questions that we have also asked to the CDC more broadly and to NIH more broadly about their firewalls protecting this data from the Department of Homeland Security, law enforcement agencies, immigration enforcement agencies, we have not gotten any real answers on those questions. And given what we know about the agendas and the ideology that are driving this administration and their approaches to federal agencies, and how particular communities are getting targeted in the service of white supremacist ideas, there's really no actual reason for us to just trust these agencies with this information right now. And so hopefully we can galvanize some momentum around this. And in terms of what we're calling for, this is absolutely connected to the movement for Black Lives. This is absolutely connected to the calls to defund the police and the calls for abolition of the carceral state, abolition of cops, getting cops out of all the places they shouldn't be, and the abolishment of ICE as an institution. It doesn't need to be there, it shouldn't be there. But we need to demand in our local communities that public health data is never connected to law enforcement, that is never connected to immigration enforcement. And those are interventions we can make at the local level.
Thank you. Thank you. Thank you. That was inspiring and amazing. Maxx, closing thoughts. You're muted, my friend.
I was saying it was hard to follow up Naina on that one. So yes to everything Naina said. I think when we think about these intersections of how it connects to this larger work of what we've seen around uprisings, what we've seen from a number of our different movements, there's an overall worry about just how in which our government, which we pay taxes for it to try to also, protect us. Also, within that, also give us also an option of better health. But we still see we have too many health inequities of showing where the communities of color, specifically Black folks and Indigenous folks, are being left out. And to continue to try to put, as Naina said, these band-aids on these problems, that's not going to work. I think we have to continue to be very ever vigilant. Making sure, and as we talked about some of the things that folks have done here working in Georgia, seen in North Carolina, seen also most recently in Illinois, and trying to make sure that there's that the use of molecular surveillance data is not used to further criminalize people, and also the further work to also in these criminalization laws. The HIV criminalization laws, and also, as we talked about in the We the People report, it can't just stop at HIV criminalization. It has to include much of the criminalization. I also want to talk about the wonderful work the Racial Justice Action Center, Solutions Not Punishment, Women on the Rise, to work for a pre-arrest aversion program here in Atlanta. And that is also something, a harm reduction strategy to also make it so folks, it's not investing more into policing, it is investing more into practices that actually give less power to policing structures and other structures to further harm communities. And those are some of the things that we have to look at of what we have seen our communities to be able to do, pre-arrest programs, policy changes on the ground, to not actually put the answer is not always to put more money into actual policing. I never think that's the answer. The answer is to actually divest from harmful things that will continue to harm us. And I would also add, not to further invest more into molecular surveillance, but actually invest in actually the inequities that we're seeing, deal with the actual poverty within our communities, actually invest in how do we tackle some of these larger issues, and actually what we should be doing within our COVID-19 response, our HIV response, and our response to racial injustice in this country is having those longer tier plans while also having short outcomes to deal with what are the issues we're seeing right now to deal with. We're going to see a huge economic impact from all of this, from COVID-19, that will also cause further inequities. And when we do start to see vaccines from this, one of our biggest worries right now at BAI is that our communities won't get the access to the vaccine that's needed, not just here in this country, but across the world. And how do we also advocate for that at the same time while not giving up our freedoms? And that means a lot of education for our people right now, and fighting again for those long-term structural changes that we need, while making sure to keep our sanity, but also keeping our folks alive as much as possible during the short term. I think that puts an extra burden on all of us in our different movements, but it makes us have to be sharper, more critical, and think about how these different things interconnect, and making sure whatever laws, if it's something that the Movement for Black Lives, folks that are trying to abolish ICE, even any of us, trying to make sure that we're moving policies that align with that, and also have them align with us, so we can move forward in creating a more just society, so where surveillance is not done in a way where it is always done in a way that is anti-Black, racist, and non-power neutral. We need to make, if anything is being surveilled on any of our bodies, to make sure that power is not with a few, but with as many people as possible, being able to make sure that it is done in a way that is equally as possible.
And then, Andy, super quickly, people need to vote this November, because it's incredible to me, the fact that we have this president right now after the 4 years that we have had, and that we actually have the face to actually engage in a discussion about his actions is pathetic. It's ridiculous. I cannot put myself to that. And so, and we have suffered, and it's very serious. We have suffered. People have suffered. People have died because this person, whatever. I wanted to tell people that they have the power to vote and to change this, because frankly, there is no way that I can have another 4 years of this, because I'm afraid that I'm gonna be killed by the administration, period. So I invite everybody, I'm not a voter, but I'm gonna drive you to the polls. I'm gonna make tamales for you. I'll just do whatever, but please go and vote and express yourself, because it's the abuses and the attacks are sometimes overwhelming, really overwhelming. So thank you for hopefully get yourself to vote this November.
Thank you, Marco. And Nana put in the chat box, I'm gonna elevate it here, votepositiveusa.org. Get into it. Martin?
I just want to say thanks so much, everybody. What a great discussion. I was monitoring the chat to try and collect questions, but you were also good at multitasking, that you just took them, and dealt with them. So there, you dealt with all the questions that came up, I thought, in the chat, but also folks put so many good things in the chat, so many great resources. So, thanks to everybody who is involved in this discussion today, our panelists, our chair, Andy, all of you watching and sharing resources in the chat. This is going to be available afterwards. Tammy, do you want to say a last word? Thanks very much to you as well, and HINAC organizers for this conversation.
Yes, thank you. I just wanted to, I forgot, I had my tape on my camera. Thank you all for your time and your expertise this afternoon. It was an amazing conversation, and you are incredible, amazing, and inspiring leaders. So I want to thank you so much. Just let everyone know, we will send out the recording link with all of the links and information that was shared today in the chat box. You can share that with your community so everyone can see this. We don't have the date confirmed for the next webinar, but watch our partner organizations will help share the announcements. So hopefully you can join us for the next Road to HINAC 4 webinar. But thank you so much, presenters. You were amazing.
Thank you for having us.
Yeah, thank you so much.
Thank y'all so very much. And Kamaria, yes, it will be recorded.
And this is Atos, you all. Say hi.
Lovely.
Say hi, Atos. Hi.
Bye.
So cute.
Thank you all.
Thanks, everyone.
Thank you.
you.
Bye.
Thanks, everybody.